I start?
I will introduce about the program. Then I will hand over the session to Hardika ma'am. She will proceed further.
Okay.
A very good evening and warm welcome to all the dignitaries present here. I am Momita from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the Indian Medical Association Medical Students Network Maharashtra. And the focus of today's session is World Hepatitis Day. So, without any much delay, let's begin today's session, for which I would like to invite Dr. Hardika ma'am to take over. Over to you, ma'am.
Thank you, ma'am. Good evening, everyone, and welcome to today's highly anticipated webinar on diagnosis and management of hepatitis, proudly organized by IMA MSN National. We are thrilled to have such an enthusiastic and diverse audience with us today. My name is Hardika, and I'm a member of Membership Subcommittee at IMA MSN National. I'll be moderating today's webinar alongside my co-moderator Sameer, who is equally passionate about advancing medical education and awareness. Before we delve into our topic, let me share a bit about IMA MSN. The Indian Medical Association Medical Students Network, IMA MSN, is a vibrant community committed to professional and personal growth of medical students across India. We aim to foster a strong sense of collaboration among the future leaders of healthcare, equipping them with the knowledge and resources and support they need to excel. Now, it is my pleasure to introduce our esteemed speaker for today, Dr. Saswat Chatterjee. Dr. Chatterjee is a renowned expert in the field of hepatology with an impressive and illustrious background. He completed his MBBS from NRS Medical College and Hospital, Kolkata, in March 2009, followed by an MD in General Medicine from the same institution in June 2013. He further specialized with a DM in hepatology from IPGMER and SSKM Hospital, Kolkata in August 2016. Dr. Chatterjee currently serves as a consultant in the Department of Gastroenterology at the Calcutta Medical Research Institute, CMRI, where he has made significant contributions to the field. His areas of interest include cirrhosis and its complications, acute and chronic liver failure, recurrent and chronic pancreatitis, cholangitis, viral hepatitis, and NASH. Dr. Chatterjee has an extensive list of publications in renowned national and international journals. We are truly privileged to have Dr. Chatterjee with us today to share his invaluable insights and expertise on the diagnosis and management of hepatitis. This is a critical topic, especially given the global burden of hepatitis and the urgent need for effective strategies to address this pervasive disease. Before we begin with the session, I request all the delegates, if you have any question regarding the topic, then please put it in the chat box and it will be answered at the end of the session. Now, without any further ado, please join me in welcoming Dr. Saswat Chatterjee. We're so delighted to have you, sir. The stage is all yours.
Madam, thank you for the kind words and the kind introduction. So, as we delve deep into this topic, let me answer certain things very clearly. First, this is more a talk to do with usual situations which we get to see on a day-to-day basis, rather than situations or diagnosis we get to see about once in a lifetime or once in a decade. That being said, we commemorate today with the outline of this talk, which we will be having today, is about what is World Hepatitis Day 2024. In simple words, what is hepatitis? How does hepatitis present? How do we approach different LFT patterns in the making a diagnosis? What are the common etiologies of hepatitis? And an outline to the treatment of hepatitis. So, this year, the World Hepatitis Day falls on 28 July, or rather fell on 28 July 2024. And the WHO theme, like many years since it has been happening, every year World Health Organization comes out with a theme. What is the theme of the day? So the theme of this year's World Hepatitis Day was, it's time for action. Why? Like the brief introduction which we had, we know that babies should receive hepatitis B vaccine within 24 hours of birth. WHO data from a couple of years back states that the total number of babies who should have received, about more than half of them do not receive. When we talk about people who are living with chronic hepatitis B or hepatitis C, we are talking about 0.3 billion people. When we are talking about people who have died from hepatitis B or hepatitis C, chronic hepatitis B or chronic hepatitis C in 2022, the figures are staggering, 1.3 million. These are huge numbers. We need to bring down the numbers. Now, 28th July happens to be the birthday of Dr. Baruch Bloomberg. He is important because this gentleman came up with the discovery of hepatitis B virus in 1967. He is also credited with developing the first vaccine developed against hepatitis B virus in 1969. And for these reasons, he was awarded the Nobel Prize in Medicine in 1976. Now, in simple words, in very plain terms, what is hepatitis? Any inflammation in the liver is known as hepatitis. Now, what do we mean by that? We mean that any inflammation due to any etiology in any degree going on in any part of the liver is defined as hepatitis. How does hepatitis present? We have clinical signs, and before that, we have clinical symptoms. When we talk about symptoms, they are usually icterus, nausea, excessive urge to itch or pruritus, anorexia, weight loss, fatigue, abdominal discomfort, clay-colored stool, and fever. But we also need to remember that some of our patients will be asymptomatic, that is, devoid of any symptoms. We also talk about clinical signs. What are the clinical signs we talk about? We talk about jaundice, shifting dullness, asterixis, spider nevi, and stigmata of cirrhosis if cirrhosis is present. Moving on with the topic, now we will have very brief discussions regarding how to approach the diagnosis. And I think it's best that we discuss it in the manner of certain certain real life cases. Let us take the example of a 42-year-old diabetic lady who presented with acute onset right upper abdominal pain. Initially, she had fever. Initially, she had vomiting. Fever subsided, but vomiting persistent. She has jaundice. The ALT, AST or the SGOT, SGPT rate are quite raised, disproportionately more high than the alkaline phosphatase. The INR is more or less okay, just a wee bit above normal. The albumin is on the low side. Now, so we are talking about a deranged liver function test where deranged bilirubin or rise in bilirubin is accompanied by a rise in SGOT and SGPT and a nearly normal alkaline phosphatase. The ultrasonography done in this lady showed mild splenomegaly, hepatomegaly, and a chink of ascites. When we are faced with this pattern, that is bilirubin is raised and SGOT or SGPT, that is to say ALT or AST are raised, we say that this pattern is hepatocellular pattern of derangement of liver function test. Moving on to the second example. An elderly gentleman was admitted with fever and jaundice, and he has got intense pruritus, which is hampering sleep at night. The bilirubin is raised. The ALT and AST, that is to say the SGOT and SGPT are normal. The alkaline phosphatase, on the other hand, is quite raised. Albumin is preserved, INR is normal. Now, on the ultrasonography, the biliary tree, that is to say the common bile duct, the common hepatic duct, the left and right hepatic duct, the intrahepatic biliary radicals are dilated. There is a common bile duct stone, and the person also has gallbladder stone. This pattern, when we get rise in bilirubin normal ALT and AST, that is normal SGOT, SGPT levels, and a raised alkaline phosphatase level. This is the pattern we allude to as cholestatic pattern of deranged liver function test. Moving on to the third pattern of deranged liver function test. We have an asymptomatic gentleman, apologies for the spelling mistake, who had a deranged liver function test on annual health checkup. Bilirubin was found to be raised. The liver enzymes, SGOT and SGPT, were normal. Albumin, globulin are normal. INR report is this is wrong. This INR is 1.6, that is normal. Alkaline phosphatase is normal. Ultrasonography done, and that is also normal. So what are we left with? We are left with an isolated hyperbilirubinemia pattern. Only the bilirubin pattern is raised. The rest of the things are normal. Moving on to another example where we have a patient who was put on anti-tubercular therapy. This patient also happened to have cirrhosis, and other than cirrhosis or splenomegaly, no liver SOL, no ascites were found on ultrasonography. The bilirubin is raised, the ALT, ASTs are mildly raised, and the alkaline phosphatase is also mildly raised. This pattern is stated to be mixed pattern of liver function test derangement. Why are these four patterns important? These four patterns are important because when we approach the deranged liver function test, we use our pattern recognition receptors to understand which pattern are we looking at here. When it is hepatocellular pattern, the AST, ALT levels are disproportionately raised with respect to the alkaline phosphatase levels. When it is a cholestatic pattern, it's entirely the reverse of the hepatocellular pattern. That is to say, the alkaline phosphatase is disproportionately raised, but the ALT, AST levels are normal. Mixed pattern is when both alkaline phosphatase and AST or ALT levels are raised. And isolated hyperbilirubinemia is encountered when only bilirubin is high, but the rest of the liver function parameters are normal. Next, we also need to understand that there is something called acute hepatitis, and there is something which is called chronic hepatitis. When is hepatitis chronic? There are debates on this subject, but for most situations, the answer is any hepatitis which is lasting for a duration of more than 6 months is said or stated to be chronic. Any hepatitis which is lasting for a duration less than 6 months is stated to be acute. There are other terms such as subacute, but the term chronic is universally reserved for any hepatitis which is lasting beyond 6 months. Now we are going to talk about common etiologies of hepatitis. We can grossly divide it under two headings: viral etiology and non-viral etiology. When we talk about viral etiology, we usually talk about hepatitis A virus, hepatitis B virus, hepatitis C virus, hepatitis E virus, and hepatitis D virus. And when we are talking about non-viral etiology, we are talking about alcohol-induced liver diseases, ischemic liver diseases, autoimmune liver diseases, drug-induced liver diseases, and metabolic or genetic-induced liver diseases. Now, when we talk about the common types of viral hepatitis, we usually talk about hepatitis A virus, hepatitis B virus, hepatitis C virus, and hepatitis E virus. Now, when we talk about hepatitis A virus, the presentation is usually acute hepatitis, or other words, acute viral hepatitis. Rarely, and it's nearly impossible to see any chronic sequelae of hepatitis A virus infection unless the person lands into acute liver failure. Hepatitis B virus, depending on the setting, can be an acute illness or can be a chronic viral hepatitis. Hepatitis C virus, like hepatitis B virus, can be an acute or chronic. Now, it is usually chronic, but sometimes, if we assume an example, a healthcare worker had a needle stick injury from a source which was hepatitis C positive. In other words, a hepatitis C patient was undergoing surgery because of any reason, any one of the people or healthcare workers present in the OT at that point of time happened to pick up a needle which was, coated in the patient's blood, and somehow managed to prick himself or herself, in that setting, the hepatitis C, if it occurs, can be an acute hepatitis C. Hepatitis E virus is usually acute. There are extremely rare situations where it turns chronic, and it is usually of academic interest only. Moving on. When we talk about hepatitis A virus, we are talking about a positive stranded RNA virus, which was identified in 1973. And usually the infection is acute and once in a lifetime because lifelong immunity is usually achieved. Once hepatitis A virus enters into our system, it enters through the fecal-oral route of transmission, and it has got an incubation period on an average of about 1 month. The tests done include IgM anti-HAV and sometimes, rarely, hepatitis A virus RNA PCR tests. When we talk about any viral infection or any disease for that matter, there is a high risk population. And for hepatitis A virus, the high risk population happens to be people who receive blood, who are hemophilia, who are imprisonated, who serve in the military, who handle food, who handle sewage, people who use illicit drugs, obviously healthcare workers and travelers. Now, do we have a vaccine? Yes. Can it be given to everybody? Anybody who is 1 year and above of age can get the vaccine. And the manufacturer recommendation states that it is either 2 doses intramuscularly at 0 and 6 or 2 doses intramuscularly at 0 at 18 months apart. Depending on the age, the site of injection chosen is either deltoid for adults or anterolateral thigh for our pediatric population. And like any other vaccine, it can be combined with other vaccines as well. Moving on to hepatitis E virus infection, which is another fecal-oral route of transmission. The incubation period is a wee bit higher. It is about 45 days, and it is also a single-stranded RNA virus. We should remember that it was first identified in India in 1978 during the Kashmir epidemic, and after more than 15 years, after about 13 to 15 years, the full cloning was achieved. When infected in the 3rd trimester of pregnancy, the rate of fatality, the rate of death is very high, and only genotype 3 in under rare situations can cause chronic infection in patients who are chronically immunosuppressed post solid organ transplant, like liver transplant, like kidney transplant. The high-risk population group for hepatitis E include people who have cirrhosis, people who live under questionable sanitary conditions, where the water supply is contaminated, undercooked fish, undercooked shellfish, and travel to endemic regions of the world from less endemic or non-endemic regions of the world. Hepatitis E virus is available in China, but not available in India. In China, the virus is against the genotype 1, HEV genotype 1, as a part of the capsid protein, recombinant part. It is given intramuscularly for people who are 16 years and up, and it comprises 3 vaccines. It is not even US FDA recommended till date. We need to remember what happens after we get infected with hepatitis A virus or hepatitis E virus. Majority of the people will remain asymptomatic. That is to say, they will not develop any signs or symptoms. Minority will develop symptoms, and even minority of them will have fatal outcomes. Non-fatal comprises more than 99% of all infections with hepatitis A and hepatitis E. For everybody, like hepatitis B vaccination post-birth, hepatitis A vaccination is unfortunately not a reality. And when we talk about hepatitis E virus, as on date, vaccination in India is not a reality. Therefore, is there any way that we could protect those who require protection? There are very simple methods to remove the virus from water. Chlorination of water, ozone treatment of water, UV filtration, ultrafiltration, distillation, even boiling water can destroy the viruses effectively. Moving on to viruses which are transmitted through blood and body fluids. We are going to talk about hepatitis B. The usual incubation period for acute hepatitis B infections to occur is stated to be around 3 months. It can be longer. I'm only quoting the average incubation period. WHO estimates from 2019 tell us that 296 million people worldwide are infected with hepatitis B. With time, the number is rising. Now, it can occur when sharing of needles takes place, unprotected coitus takes place. It can also be transmitted from an infected mother to her child. This is a DNA virus, and this is the virus which was identified way back in 1965 by Dr. Baruch S. Bloomberg. There are plethora of tests which are employed when we talk about whether to treat a hepatitis B patient or not. Hepatitis B vaccine, like we all know, is available. There is no minimum age. It can be given as soon after birth as possible. It is intramuscularly given, and usually 3 doses are recommended at 0, 1, and 6 months interval. When we talk about hepatitis C infection, this is again transmitted through blood and body fluids. We are talking about a shorter incubation period, lesser number of people who are infected worldwide. This is an RNA virus, and healthcare workers, like the example I was telling about a bit earlier, after needle stick injuries, and people who had transfusions or organ donations before 1992 stand at risk of developing HCV infection. Why 1992 June? Because around that point of time, hepatitis C testing became mandatory. Blood and blood products began to be tested extensively for hepatitis C virus around that point of time. And around that point of time and afterwards, people became more bothered about this virus rather than before. It was discovered in 1989, relatively more recently. When we talk about all the viral hepatitis, no vaccine for hepatitis C is available till date. Therefore, this cannot be prevented by any vaccination till date. How to prevent this? For like any other viral infection which is transmitted through body fluids, precaution is probably far better. We have vaccinations for hepatitis B. Unfortunately, no vaccination for hepatitis C till date. We have antiviral agents for both hepatitis B and hepatitis C infections. As needed, they should be used. As a prototype for progression in patients who have chronic hepatitis, I have, like many of its type, I have chosen only one disease. I have chosen to put in 3 names. Non-alcoholic steatohepatitis subsequently became known as metabolic dysfunction associated fatty liver disease, subsequently became known as metabolic dysfunction associated steatotic liver disease. These 3 basically stand as names of the same disease. It's just that with time, the name changed from the left to the right. When we have a healthy liver in a genetically susceptible host with environmental stress, and under the circumstances the person is in, few of them will develop excess fat in the liver when we talk about this disease. That number is about 1/3. Out of everybody who has developed excess fat, inflammation in the liver will be seen in about 20 to 25%. Out of everybody who has got inflammation in their liver, 1 out of 5 is probably going to develop cirrhosis. And once they develop cirrhosis, about 2 to 3% people will unfortunately progress to HCC. The point I'm trying to make here is all chronic hepatitis behave in an identical fashion. The percentages differ disease by disease. The rate of progression from one stage to another differs between the diseases, but the basic concept remains the same. Everybody who is susceptible does not develop the disease, and everybody who is developing the disease does not progress at the same rate. Also, few people jump stages and develop hepatocellular carcinomas. NASH, or non-alcoholic steatohepatitis, is an example where a patient can develop hepatocellular carcinomas in the absence of development of demonstrable cirrhosis anywhere in the liver. Moving on, we talk briefly about drug-induced liver injuries and briefly about the outlines of genetic liver diseases. When we talk about drug-induced liver injury, we should remember that it is a great masquerader. That is to say, it can present in multiple forms and it can mimic many diseases. Fortunately, it is very rare. We can have acute hepatitis patterns, we can have chronic hepatitis patterns, we can have cholestatic hepatic patterns, which may be acute or chronic, we can also have bland cholestasis, we can have granulomas formed, we can have cirrhosis formed, we can have zonal necrosis formed, we can have submassive necrosis. Sinusoidal obstruction syndrome is more commonly described because chemotherapeutic agent induced liver damage is pretty common, though not always very extreme. Liver tumors have been known to occur in experimental studies. Mixed injury in liver diseases can also occur. When we talk about monogenic liver diseases, we can classify them in many ways, but we can divide them under grossly three headings. A, diseases which are primarily liver damage, such as PFIC or Alagille syndrome or genetic cholestasis, Wilson's disease, hereditary hemochromatosis, tyrosinemia type 1, alpha 1 antitrypsin deficiency, glycogen storage disease type 1, or ASL or arginosuccinidic aciduria. We also have monogenic diseases which can affect both liver and extralivertic tissues, such as organic acidurias, cystic fibrosis, Gaucher's disease, and porphyria, erythropoietic protoporphyria. We can also have diseases which are due to genetic causes, but they affect liver without significant liver parenchymal damage. The list is extensive. I have a disclaimer to make. I rarely get to see any of these diseases. Therefore, probably I am not the best person to talk about these things. Now, if we go back and look at the patterns of liver function test in damage which occur, we have the hepatocellular pattern, we have the cholestatic pattern, we have the mixed pattern, and we have the raised isolated hyperbilirubinemia pattern. When we talk about the hepatocellular pattern, it's more likely that it is a hepatitis A or hepatitis E or hepatitis B or hepatitis C virus infection. Sometimes it is a liver abscess. Sometimes it is autoimmune hepatitis, Wilson's disease, rare viral infections such as hepatitis, herpes simplex virus, Epstein-Barr virus, cytomegalovirus, sometimes varicella zoster virus as well. Sometimes it's a drug-induced liver injury. When we talk about cholestatic liver diseases, majority of them have gallbladder and CVD stones. Some of them have CVD stones or CVD strictures. In short, biliary obstructions. PBC can also present with cholestatic pattern. Autoimmune hepatitis sometimes has overlap with PBC and can also have cholestatic patterns. Drugs can also mimic cholestatic hepatitis. Mixed patterns usually have components of both. Isolated hyperbilirubinemias are usually found in situations where it may be either conjugated or unconjugated bilirubin, which is predominantly raised. We can have hemoglobinopathies, we can have autoimmune diseases, we can have Wilson's disease, we can have strictures as well, and genetic diseases tests and liver biopsies are very important. Of note that liver biopsy is probably taken as the gold standard for diagnosis in several chronic hepatitis. It is used selectively, not in everybody, when either A, the diagnosis is in doubt, or B, the findings might change the treatment, or C, when the clinical presentation does not match what the hypothesis that we have for this patient. If we were to divide these these types of tests, there are a set of tests where the usual answers lie, and there are a set of tests where sometimes the answers might lie, not always. This is a busy chart which serves as one of the several examples in which Didion's liver function test is approached. Suppose alcohol intake is suspected. Then we look into the alcoholic hepatitis algorithm. When there is cholestasis, ultrasonography being normal, other liver etiologies are looked into. When there is isolated raised bilirubin, Gilbert syndrome is undoubtedly the most common. Hemolysis is also quite common. When we have a synthetic failure of the liver or hepatitis type of pattern without synthetic pattern, we just differentiate them two. Well, that is to say, if there is a hepatitis pattern and there are features of liver failure, this can include bilirubin more than 3 in some situations. For most situations like acute hepatitis, it is usually more than 10. Low albumin, prolonged INR, ascites, GI bleed, or when we have malignancies, these warrant an urgent referral. When there is hepatitis pattern, it might be non-alcoholic fatty liver disease or metabolic syndrome or MASLD. It might be non-MASLD and viral hepatitis. Now, as a matter of how we approach the treatment, that is to say the principles of treatment, we need to identify syndromes. Is it an acute hepatitis only, an acute hepatitis with liver failure, which makes it an acute liver failure? Or is it an acute hepatitis superimposed on a chronic liver disease, making it an acute on chronic liver failure? We need to identify treatable etiologies. Hepatitis B, hepatitis C are treatable etiologies. On that note, there are treatment options for Wilson's disease. There are treatment options for autoimmune hepatitis. Yes, they should also be considered. When we have a culprit agent, say certain medicines such as anti-tubercular therapy, which are in our country probably are the best possible examples of causing hepatitis in the highest number of patients, alcohol intake, which is also very common. In fact, alcoholic hepatitis is alcohol, hepatitis B and hepatitis C are the three topmost causes of cirrhosis worldwide. NASH is not very far behind. Now, the person also is put on, in very plain terms, liver support therapies. If there are organ failures or organ impairments such as renal impairment, cardiovascular impairment in the form of shock, or respiratory impairment, that organ also needs attention. And in situation when the person has got a liver failure, which might be acute or acute on chronic liver failure and sometimes also decompensated cirrhosis, the person needs to be taken up or considered for liver transplantation. With that, I conclude my talk and I will be happy to take any questions.
Hello.
Hello.
Hello. Very good evening, sir. Thank you for such a great explanatory part of hepatitis. I think Hardika, you may continue. Momita,
Yes,
is
sir.
there any questions in the chat box?
Yes, sir. Just allow me a moment, sir. I'm checking whether I'm receiving any questions or not.
Yes,
Sure.
please.
If anyone hello, if anyone have any questions, so directly ask to me, sir.
Since there are no questions, now I would like to conclude this enlightening session on Hepatitis Day. I would like to take a moment to express a heartfelt gratitude to our esteemed speaker, Dr. Saswat Chatterjee, sir. your insights into the prevention, treatment, and awareness of
Just a
hepatitis.
moment, ma'am. I'm checking, ma'am. Actually, there is some network issues from my end. Just allow me a moment. I'm checking whether I am receiving any questions or not. So, just a moment.
Oh, no.
Okay, if I may be allowed, I will give you a little bit of tidbits into hepatitis during this time being. Am I? Can I continue, madam?
Yes, sir. Sure. Yes. Please, sir.
Okay. When we talk about hepatitis B virus mothers, and when we talk about the number of children who, from these mothers who develop hepatitis B, we need to remember a fact. Say 100 mothers are unfortunately hepatitis B virus positive. The virus is in circulation in their body. Now, it's only when high volumes of the virus are in circulation or when the person is having E antigen positive disease that the chance of viral transmission is higher. Also, when we talk about these kids, most of these kids will fortunately not acquire hepatitis B virus. When we are talking about high levels of transmission from mother to child, we are talking about typically in the range of 15% of all children. Fortunately, most children do not acquire hepatitis B virus. When we talk about the best possible precautions and preventions being taken, that is to say, hepatitis B immunoglobulin in one limb and hepatitis B vaccine in the other limb, not at the same side because they will neutralize each other. Then we are talking about a rate of transmission to children to the tune of about 5 to 6%. So that's the best that we can achieve. Once a virus such as hepatitis B is in circulation, part of it homes into the genetic material, and the genetic material of the virus usually makes itself at home within the liver cells. When we talk about eradication of hepatitis B virus, we are talking about the cells which are infected with hepatitis B. They must die without infecting the other cells of hepatitis B. There were attempts to eradicate hepatitis B by killing cells this way, but theoretically, several patients, theoretically speaking, will land up in liver failure because most cells of the liver are affected by hepatitis B. For such situations, because it is a complex virus, we have several nomenclatures. We have stages such as inactive hepatitis. We also can simplify either as classification into 4 forms when we follow the American classification. We have hepatitis B and E antigen positive disease and hepatitis B E antigen negative disease. And we have hepatitis and infection. Now, the Americans define infection as presence of hepatitis, presence of hepatitis B without evidence of inflammation in the liver. When we have chronic hepatitis B with inflammation in the liver, it is hepatitis. That's how, if we were to choose the 4 terms, it would be hepatitis B E antigen negative chronic hepatitis B viral infection, hepatitis B E antigen negative chronic hepatitis B virus hepatitis. And if you were to change the names from E antigen negative to E antigen positive status, we will have the rest of the things. Now, when we talk about hepatitis C virus, 15% people, as a rough figure, are able to have a viral infection which got eliminated spontaneously. Majority of the patients might not require treatment, but if we were to test them, majority of the patients will have virus in circulation based on the data that that I just pointed out. Now, the only way to decide whether hepatitis C virus is requiring treatment or not is to see whether hepatitis C virus RNA is in circulation or HCV RNA, and quantitative tests are preferred. Now, when hepatitis C virus RNA is in circulation, treatment is given based on standard durations. After the durations are over, majority, if not everyone, will get rid of their hepatitis C virus in circulation. But anti-hepatitis C virus antibodies, which are created by the host, usually stay. There are rarely we get to see loss of anti-HCV antibodies after successful antiviral therapy. It is not entirely unheard of or not seen, but yes, it does occur. Spontaneous clearance of hepatitis B virus from circulation is rarer. When we talk about hepatitis A virus or hepatitis E virus, some of them, most of them, resolve on their own within a period of about 4 weeks. Few of them can last up to 3 months or more. But more than 6 months is usually something we do not get to see. When we talk about alcoholic hepatitis, or when we are looking at a person with alcoholic hepatitis or deranged LFT with the history of alcohol intake, there are two aspects to it. One, the hepatitis part, and two, the alcohol part. The person might have warning encephalopathy, might have alcohol withdrawal. Those things need to be looked into. Those issues need to be addressed. The person also has hepatitis, that also needs to be addressed. The classical descriptions in our undergraduate textbooks regarding acute liver failure drug-induced happens to be paracetamol. Paracetamol is a pretty common cause of drug-induced acute liver failure in the Western countries. In India, it is not uncommon. Across our country, it is usually more common to see anti-tubercular therapy as the culprit. We do get to see paracetamols. We do get to see poisonings. For some people, treatment might not be yielding great results. Say, we were to assume a situation where a person has got disseminated malignancy and both lobes of liver are studded with metastasis. That situation will also have what we call hepatic parenchymal extinction. That is to say, the effective liver volume is quite low. When the effective liver volume is quite low, we can have a feature which mimics acute liver failure. Not all situations will have a good treatment, but at least we need to get the etiologies which are treatable or curable. That is something we should concentrate on very sincerely and try to reduce the symptoms in all patients as a whole.
Thank you so much for the insight, sir. Now, with your due permission, we continue with the Q&A session. We have a question from Dr. Jatin Jindal. He asks, and I quote, "So what about the treatment and prevention of NAFLD?"
Well, the treatment of NAFLD is in evolution. The prevention of NAFLD is something in our hands. I'm not very sure, but I believe most of us didn't spend our entire lives looking at books and hearing lectures. We also used to play. Now we do not play, we eat more. If we were to reduce those two and go back to our good old days, we will have our prevention of NAFLD. When we look at what we call the westernized lifestyle with respect to what we call the indigenous lifestyle, the people who have fatty liver, they are not only restricted to our cities, they are also found in our countrysides. But on an average, the average physical labor done in our countrysides is much more. So we need to sweat it out in plain terms. We need to have an intake of lesser kilocalories and have we need to use more kilocalories than we have taken in. That is the only thing which will ensure a negative energy balance, and which will in turn have its effect on our body energy stores, translation fat stores, and therefore we are going to lose fat from all over our body, liver included. As far as treatment of NFLD is concerned, scientifically speaking, it depends on the stage in which we are seeing the patient. When we are looking at bland fatty liver, that is to say fatty liver without inflammation, reducing the fat is all that is going to take care of the situation. Very importantly, the diet control and exercise needs to continue, because many people do not continue it, and despite continuing it, several people are not successful to maintain the same amount of weight loss after a period of time. Say a 100 kg man is supposed to lose 10 kgs, 10% of his body weight. Most people will achieve that. Not everybody, but most. But once people have achieved that, researchers have gone back to them after 1 year and to see how many of those people, the 10 people who could achieve weight loss of 10%, could maintain the weight loss. The researchers found that about 10% people, that is to say 1% out of 10, could maintain the weight loss. It's easy to lose weight, it's difficult to maintain weight loss. That's something we need to remember. Secondly, when we talk about steatohepatitis, that is to say there is an inflammation ongoing in the liver, there are many agents. If you look at the guidelines, some of the agents which we get to see used in our day-to-day practice are not backed up by guideline data. There is anecdotal evidence, there are case reports, and some of the evidence is backed up by guidelines and meta-analysis. When we talk about vitamin E, yes, it works. When we talk about certain other aspects, they also work. When we talk about agents which treat the primary pathology, say a person was hypothyroid, got obese, treat the hypothyroidism, institute exercise, the person's fatty liver will reduce. Say, for example, a person has got diabetes. Diabetes needs to be controlled. Cholesterol problems, dyslipidemia, that needs to be controlled. Now, when we are talking about a steatohepatitis which has progressed to cirrhosis, we are talking
Sir,
about.
sorry for the interruption, sir. There are so many questions we have received from our participating doctors. So may I have your permission to put them across?
Please.
I am putting all those questions in the chat box, sir. Okay.
Okay. So I need to open the chat box. That will be in the notes or whiteboard.
So it would be in the
No,
chat
sir, you
section.
have to
If
check
you
the
wish,
chat
you
box,
can
sir. Zoom
read it
chat
for you.
box.
I got it. I got a chat box.
Sir, just now I have put it a question. Can you please say it, sir? Is it visible?
I have one question which is visible. What is the treatment and prevention of NFLD?
Type of session है ना? वहाँ पे multiple doctor है.
So, madam, can you do me a favor? Just read one question. I will answer that question and we will move to the next.
Sure, sir. We'll narrate the question to you and you can continue accordingly. Thank you.
I got one new message. Please repeat case discussion once again along with the treatment approach. Okay. So in very plain terms, look at the pattern. Is the bilirubin high? Yes. Are the SGOT, SGPT or ALT, AST high? Yes. Is the alkaline phosphatase high? No. The pattern is hepatocellular pattern. Is the bilirubin high? Yes. SGOT, SGPT high? No. Alkaline phosphatase high? Yes. It is a cholestatic pattern. Bilirubin high? Yes. SGOT, SGPT high? Yes. Alkaline phosphatase also high? Yes. Mixed pattern. Bilirubin high? Yes. SGOT, SGPT high? No. Alkaline phosphatase high? No. Isolated hyperbilirubinemia. That's how we go with the treatment, we go with the approach. As far as treatment approach is concerned, what is the etiology? Is there any treatable etiology? What is the severity of the disease? What is the stage of the disease? Is the liver only affected, or are organs other than liver are also affected? That's how we go about it. That's to answer Dr. Kartikeya Singh Chandal's question. Now we have a question from Dr. Muhammad Adnan Ismail. What are the indications for liver transplantation in chronic hepatitis? In one word, acute liver failure, acute on chronic liver failure, and some patients who have advanced decompensated cirrhosis. Moving on to answer in brief. Now, please explain about the treatment of chronic hepatitis B of treatment, its duration and its prognosis. Well, it's a huge discussion. I don't think I can have the discussion in an hour, but in plain terms, patients who have hepatitis or inflammation in the liver, hepatitis B positive, hepatitis E antigen positive, and HBV DNA more than 20,000 IU per ml, or patients who have HBe antigen negative, HBV DNA quantitative more than 2000 IU per ml and evidence of inflammation, or any patient with any detectable hepatitis B virus DNA and having cirrhosis, or a patient who is to be put on an immunosuppression therapy, say a malignancy, a cancer survivor, has to be put on a chemotherapy, and there is any detectable HBV DNA in the person, needs to be put on hepatitis B infection. Its duration, there are protocols for it, and its prognosis is quite good once treatment is started. Untreated hepatitis B virus usually has a worse treatment in the long run in general than treated hepatitis B virus infections. That is to briefly answer Dr. Swati Arunachalam's question. Dr. Harika Gangulla asks, can cirrhosis lead to carcinoma? Yes, madam. Cirrhosis can lead to malignancies. Hepatocellular carcinomas are very common in cirrhosis. If I have to quote one figure, it's about 3% per year. Now, Dakuri Akanksha asks, is dialysis a risk factor for ACV infection? Madam, yes, a dialysis is a risk factor for ACV infection. And if so, how can we prevent it? We cannot prevent every episode. Patients who undergo dialysis are periodically tested for hepatitis B, hepatitis C, and HIV. People who have hepatitis C are usually put on a separate machines, which are also known as positive machines, which are also have single use dialysate systems. That is to say, the dialyzer is usually not reused. People who have hepatitis C virus in circulation are treated. People who have been successfully treated for hepatitis C virus infections have a period of observation, that is to say a step down machine, and then they are taken back to the usual machine after a period of time. That is the usual protocol followed across most dialysis centers that I know of. Dr. Ashutosh Tiwari asks, when do we undergo orthotopic liver transplantation? Is there any criteria for hepatitis B positive candidates to receive a liver? Well, hepatitis B positive patients and hepatitis C positive patients cannot donate liver in India. But hepatitis B positive patients or hepatitis C positive patients can receive an organ in the form of a liver transplantation. It is reserved for patients who have got liver failure. It can be either acute liver failure or acute and chronic liver failure. Like any transplantation, it is preferred that prior to the transplantation and during the transplantation, viral load should not be detectable or the virus should not be in circulation, because the new organ is not infected with the virus in question. The new organ, once put in, if the virus is in circulation, it will again home into the new organ, and that thing will also get infected. Therefore, yes, the criteria for transplantation is the same as criteria for other people, for any other disease where people undergo liver transplantation. It's just that we prefer that virus is not in circulation. Well, Shravani Gaikwadji has got a comment. I thank you for that. And it's basically comes from the American College of Gastroenterology and the American Association of Study of Liver Diseases. It's a concept which is well structured here. It is also well known from earlier, just not discussed in that details in our UG days. Now, NASH or MASH or NAFLD? That's from Professor Dr. Kamal Krishna Bonik. Well, sir, the latest nomenclature is MASLD, metabolic dysfunction associated steatotic liver disease. It is formed by a consensus of several countries worldwide and their hepatology associations. The term which it replaces is non-alcoholic fatty liver disease or metabolic syndrome or MASH or NAFLD. The latest terminology happens to be MASLD, M-A-S-L-D, metabolic dysfunction associated steatotic liver disease. We have a next question from Dr. Kartikeya Singh Chandal. Can vildagliptin caused raised SGOT, SGPT? Usually no. Usually no. But we all get to see what we call, we have two types of drug reactions or drug-induced liver injuries. One is dose-dependent, like paracetamol. Higher doses lead to liver damage, lower doses don't. We also have something called idiosyncratic drug reactions, which cannot be predicted. And we can also have some reactions which are more like, allergy reaction things. So delayed type reactions can occur, but usually it is more because of the reason why which it has been prescribed rather than the medicine itself. Dr. Sakshi Pandit Deshmukh asks, NFLD is too common these days. What all things can prevent this? Control on our dietary intake, increase in our physical exercises can probably contribute to more control of fatty liver, non-alcoholic fatty liver disease. When we have underlying etiologies such as diabetes, dyslipidemia, those things need to be controlled. Hypertension alone per se usually does not lead to non-alcoholic fatty liver disease, but those are the some things we need to look into. Professor Dr. Kamal Krishna writes, highly appreciated today's phenomenon. Said, thank you. It's just a talk. Thank you for the kind words. And we also have thank you comments from Dr. Prithviraj Vilas Kumkar, Professor Dr. Kamal Krishna Bonik. I believe these are all the comments that I can look into. I thank you for the kind comments.
Thank you so very much, sir, for answering all the queries of our delegate doctors. And thank you to all the delegates for your valuable questions and comments. And so these all are the questions from today's session, sir.
Okay.
So now I would like to, Samir Khan, moderator for this webinar, would like to conclude this enlightening session on Hepatitis Day. I would like to take a moment to express a heartfelt gratitude to esteemed speaker, Dr. Shashwata Chatterjee, sir. Your insights in the prevention, treatment, and awareness of hepatitis have been truly invaluable. You have not only educated us about different types of hepatitis, but also inspired us to take action in our communities. IMA MSN appreciates the time and effort you took to prepare for this session and for sharing your expertise with us. Thank you once again for your enlightening presentation. On behalf of IMA MSN and membership team, I would like to thank the IMA MSN dignitaries, Dr. R.V. Ashokan sir, National President IMA, Dr. Sharad Agarwal sir, immediate past National President IMA, Dr. Anil J. Nayak Kumar sir, Honorable Secretary General IMA, Dr. Kshitij Bali sir, Honorable Finance Secretary IMA, Dr. Shalabh Gupta sir, National Chairman IMA MSN, Dr. Akshay Yadav sir, Convener Standing Committee IMA MSN, Dr. Arjit Bansal sir, Convener IMA MSN National Council, Dr. Muskan Somani, Secretary IMA MSN National Council, Dr. Meher Kaur, Joint Secretary IMA MSN, Membership Subcommittee, and a digital partner, ClearNet. Thank you so much.
Thank you so much, sir, and thank you so much, everyone. So now, with all due permission, I'm closing the session here for today, and looking forward to hosting you again. Till then, take care and bye, and have a good night to all of you. Thank you so much.
Thank you. Good night.
Good night.
Thank you, sir.